Endometriosis Medical Management, especially for adolescents. We all know endometriosis is disabling disorder where endometrium grows in ectopic position other than uterine lining. This endometriosis in India, it accounts for more than 1 million cases per year. It has significant social, public health and economic implications. Most common symptoms of endometriosis is mainly dysmenorrhea, chronic pelvic pain, dyspareunia, menstrual irregularities, and if the disease is severe, then infertility also. The sad part is there is no permanent cure for this disease. The treatment mainly aims to ease the symptoms, but diagnosis should be made early and treatment should be started early. The gold standard for diagnosis still remains laparoscopy. With this background, I invite and request Dr. Pai sir to kindly take over. Welcome.
मी हा पेन घेऊ का तुमचा? नाही.
Others, please mute yourself.
Yeah. Good evening to everyone. It's again a pleasure to come back to RATLAM, but I don't know when I'm going to physically visit RATLAM. Anyway, today's topic is endometriosis medical management, especially in adolescents. So I will straight away jump into the specific area, that is medical management, and another specific area, adolescents. So you can understand that today I will not be talking on infertility and other aspects, surgical aspects. Before we go to the medical management, we need to understand a little bit of pathogenesis, because most of the medical management is directed towards this. Obviously, it is multifactorial. First one is, of course, the ectopic endometrial tissue, which flourishes outside the uterine cavity. This may be due to an altered immunity. Otherwise, usually the cells do not flourish or survive in its ectopic region. There could be an imbalanced cell proliferation. It is not an unchecked proliferation like in cancer, but there is definitely an imbalanced cell proliferation in ectopic situation that could be contributing to the problems of endometriosis. Apoptosis is another nature of most of the cancerous cells, which can also be seen in endometriosis. In a way, if we very briefly recall the different theories, one of the theories of endometriosis is the implantation theory, or other theory which says there is a migration theory. That means there is a metastatic theory. Then what is the difference between cancer and endometriosis? The question definitely arises. In cancer also we see metastasis, that is the cells metastasize from one place, that is the main cancerous area, to another place and flourish there. If you see, in a way, endometriosis also has a similar nature. That means the endometrial cells, they metastasize, they move either through vascular channels or through lymphatic channels. They go and establish elsewhere and they proliferate there. But then the slightest difference is that the proliferation that happens is imbalanced, but it is not unchecked. One of the hallmarks of cancer is unchecked growth, okay, bizarre growth. Then there can be an aberrant endocrine signaling. The endometrium follows a hormonal or endocrinal signaling, which is different when it is inside the uterine cavity. It is different when it is in the myometrium, which we call adenomyosis, and it is totally different when it is outside the uterus. And finally, genetic factors. No disease can be explained without genetic factor. 6 genomic regions are associated with endometriosis. So you can make out that endometriosis is not a very simple disease, and there are so many things that are involved in this. That's exactly why even today, the management of this, whether it is surgical management or medical management, has not been very successful. Somehow we are dodging this particular problem with the hope that once the lady attains menopause, when totally the hormones sort of cease to provide energy or provide manure to grow, we have to somehow deal with this problem. The clinical features, all of us know this is undergraduate stuff, but it depends upon the site, depth of lesion, and do not always correlate well with the extent of disease. What it means is that all of you know that there are 4 stages of endometriosis, which I'm not going to elaborate today. But stage 1 and 2 sometimes can be very painful, whereas stage 4 may be frozen pelvis, totally painless, or vice versa. That's the meaning of this. So the stage does not correlate with the symptoms of the patient. This is the famous 5D, that's what we always explain to the undergraduate students. Dysmenorrhea, specifically that is triple dysmenorrhea, which means premenstrual, menstrual, and postmenstrual. Dyspareunia, dysphagia, that means difficulty in passing motion. Dysuria, and chronic dull aching pain. Menorrhagia is another symptom of endometriosis, which is because of the congestion in the pelvis. And of course, all of us correlate endometriosis with infertility. But today, since I'm going to stress on the medical management, that too in adolescents, I'm going to delete these 2 problems, that is dyspareunia and infertility. What is very important to understand is that 30% of the patients are asymptomatic, even sometimes throughout life. They are the lucky ones. They have endometriosis, but they may not have any major symptoms. So they may not present to you with a problem of endometriosis, and the endometriosis may remain undiagnosed in these patients in a dormant state. Now, ISHRAE in February 2022, in its latest guidelines, said as far as diagnosis is concerned, laparoscopy is no longer the diagnostic gold standard. Madam Maheshwari said it has been a gold standard. I was also teaching till February 2022 that laparoscopy is a gold standard test. Of course, in a way, it is gold standard in the sense when you do laparoscopy and if you find those kind of findings, endometriosis can be diagnosed. The meaning of this particular sentence is that you don't always have to do laparoscopy. Probably the wording should have been like that. Laparoscopy need not be done always. Instead of that, they have worded it like this: laparoscopy is no longer the diagnostic gold standard, which means there are multiple other ways of diagnosing, sometimes even empiric treatment, like we used to do in tuberculosis. For example, most of the diagnostic tools fail us in tuberculosis. The best CB-NAT, what we say, also is not 100% gold standard. It is only 50 to 60% sensitive and specific. And other situations, we may have to simply give empirical anti-tuberculous treatment, and if the patient improves, it proves the diagnosis. Same way with all the research that has gone over so many years, the recent advance, that is 2022 February, we are saying empirical treatment can be a diagnostic tool in endometriosis. Please don't be surprised with this sentence. We have come back to that situation. In my next slide, you will realize what are the different ways we can diagnose the endometriosis. It is now only recommended in patients with negative imaging results, that means ultrasound or MRI or both, and or where empirical treatment was unsuccessful or inappropriate. This particular sentence tells me what I was telling 1 minute before. That is, you can diagnose endometriosis now by ultrasound, MRI, and even giving empirical treatment without doing a diagnostic laparoscopy. Only when all these three are negative, and if the patient does not improve with the empirical treatment, then you can do a laparoscopy to find out what else is causing this chronic pelvic pain in this particular girl or a lady. I hope I'm very clear about what I have said so far. So as far as diagnosis is concerned, ISHRE 2022 guidelines recommend the following. Number 1, symptom diary or app or questionnaire. This will be very useful in early diagnosis. Many a times you can diagnose endometriosis for sure by one simple symptom, that is triple dysmenorrhea. If a person has got triple dysmenorrhea, it is almost 100% sure that she is having endometriosis. Of course, other things like dull aching pain, dyschezia, dysuria, and dyspareunia will have so many other reasons for reasons behind them. Whereas triple dysmenorrhea is almost a hallmark of endometriosis. So that means you can diagnose endometriosis by symptom alone, number 1. Number 2, vaginal endoscopy. Now, abdominal endoscopy is so difficult. I mean, you have to have general anesthesia, and you have to have instrumentations, you have to have expertise and all those things. Whereas vaginal endoscopy, especially to diagnose deep situated endometriosis, DIE what we call, but unfortunately it has got low diagnostic accuracy. Number 3 is ultrasound or MRI, but again what they have given is negative results. They do not exclude the diagnosis. That means, suppose there is an endometriotic cyst, it is very easy to diagnose by ultrasound, also by MRI. But if there are simply like early signs of powder burn mark or adhesions, sometimes ultrasound will miss the diagnosis. But that does not rule out the existence of endometriosis. That is the meaning of this particular sentence. Then, as I've been telling last 5 minutes, that empirical treatment itself is a diagnostic tool. You give this treatment for 6 weeks or so, and the patient tremendously improves. You have proven the diagnosis without doing an ultrasound, without doing MRI, without doing diagnostic laparoscopy. When all of them let you down, you may consider laparoscopy. So laparoscopy is not the first line. It is not even considered the gold standard anymore. Only if there is all the problems with the above three, either of the above are not diagnostic, you may consider laparoscopy. So just because you have a laparoscopy in your hospital, don't put laparoscopy in every single patient who comes with pain abdomen. You can straight away consider the diagnosis of endometriosis and start treating. After all, what are you giving? You are giving some painkillers. You are giving some anti-hormonal treatment. That is not going to harm. Whereas laparoscopy is definitely an invasive procedure. It should be kept as a last resort. Now, histopathological evidence at laparoscopy, is it necessary? Of course, it is always good to prove that what biopsy you have taken definitely says that it is endometriotic tissue, but negative results do not exclude. So, which means ISHRE has given us a very, very broad, scope to diagnose endometriosis. What is definitely not recommended is biomarkers. There are so many biomarkers that have been tested. It takes another 40 minutes lecture. I am not going to explain any one of them today. Simply, if anybody comes and tells you, usually the lab people will come and tell you that we are doing so many biomarkers for these things, CA125, for example. It is all very non-specific, not at all recommended. Then comes the category of no evidence. You may offer, follow-up and psychiatrist support when diagnosed early, although benefits are questionable. So this is as far as the diagnosis is concerned. Now I come to the management. There are mainly two problems in endometriosis, whatever may be the origin of it, or whatever may be the risk factor for it or whatever may be the diagnostic tool, finally, we are dealing with two main problems. One is infertility, other one is pain. And today, as I said, I'm not going to talk on infertility at all. So straight away, I will jump to the management of pain. So when we manage the pain due to any condition or any reason, we need to understand why there is pain in that particular condition. As far as endometriosis is concerned, the pain is due to three reasons. So what are the three reasons why we have pain? One is the nociceptive pain, other one is inflammatory pain, other one is the neurogenic pain. Now, whatever it is, the standard care for pain is either surgery, you remove a particular swelling or a tumor or whatever it is, and or you give medicine. So let us look at what has been the recommendation. Endometriosis is a chronic disease. So whenever a disease is chronic, surgery is not going to help much. That requires a lifelong management. In fact, as far as endometriosis is concerned, luckily, the management may be stopped after she attains menopause, because after menopause, there's a drastic decline in endometriosis. So we have to use this to maximize the advantage to the patient, avoiding repeated surgery. What are the principles of treatment? The decisions are usually individualized and they consider the clinical presentation and severity of symptoms. We know all these basic principles. Location and extent of the disease, age and reproductive desires, surgical complications, and medical side effects. So these are the things usually are variables, so to say, considered in a treatment. Of course, above all that is the cost. What are the problems with surgery? Recurrence is the biggest challenge as far as endometriosis is concerned. We have seen sometimes you have removed successfully endometriotic cyst. Within 3 to 6 months, they recur. When they recur, you have to do repeat surgeries. When you repeat surgeries, the surgeries become difficult every time. And then obviously the complications will increase as the number of surgeries increase. Then you need to have an